This is a collaboration between CSU Extension and the Alzheimer's Association of Colorado, the Colorado Department of Public Health and Environment. And, we really share the goal of community-based education. And this is an important topic. As you know, our communities are aging, and the more educated we are, the better. You're going to receive a lot of really great information. I want to give Ginger Williams credit for actually organizing this webinar. Ginger cannot be with us today. She had a family situation come up. I am using Ginger's Zoom account. That is why my name says Ginger Williams. But for those of you who do not know me, I'm actually the host here. So I'm Sue Schneider. I'm the state health specialist with CSU Extension. But hopefully many of you know Ginger and all of her great work. And she's really played an incredible role in putting all the logistical pieces of this webinar together. As I mentioned, we're going to hear from Kelly Osthoff, who's the Senior Director of Programs at the Alzheimer's Association of Colorado. And we're also going to hear from Joy Akey, who is our Family and Consumer Science Specialist with CSU Extension. I'll do deeper introductions in just a minute. But I just want to say that after this session, we're just going to ask that you please complete a short 3-minute survey that just lets us know what your feedback is about how the survey went. That will really help us develop future webinars for you. So that's really important. It will just pop up. So just hang out for a minute longer on the webinar and that survey will pop up. I also want to just make sure we state that we are an equal opportunity access and non-discrimination organization, really wanting to ensure that all of the resources, all of the community education we put out there is accessible to all. So just so you know, we are video recording this webinar. We are going to be translating the webinar and all of the materials that you will receive after the webinar. So you will receive a follow-up email from Ginger with the webinar materials. And we are committed to making sure we are posting the video and the materials in Spanish as well as English on our health extension email, which actually maybe Natalie can pop in the Q&A so people know where they're going to be able to find this information afterwards. And again, Ginger's going to be following up with all the participants with these materials. So that is what I wanted to share. And I am now going to introduce Kelly Osthoff. So Kelly is the Senior Director of Programs at the Alzheimer's Association of Colorado, where she oversees the education and support of those facing dementia across the state through the delivery of classes, support groups, and individualized care consultation services. She is also the co-chairwoman of the E-Workgroup, which stands for Empower and Engage, of the state's Colorado Department of Public Health and Environment's Alzheimer's Disease and Related Dementias Action Coalition. She has a master's degree and a postmaster's certificate in gerontology and is currently a doctoral candidate earning a PhD in gerontology with a specialty in dementia care and family caregiving. So we are super fortunate to have Kelly here sharing this information on this important topic. I just want to encourage you one more time, especially for those that might have just popped on, that you can feel free to enter your questions as we go in the Q&A. We could not enable the chat because of the webinar format of this, but go ahead and enter your questions in the Q&A. We'll keep an eye on those. And we will take questions after both Kelly and Joy have shared their information. So I'm going to hand it off to you, Kelly. Thank you so much for joining us.
Yeah, thank you, Sue and colleagues, and to everyone at Extension and Engagement for offering this great educational opportunity. As Sue said in my introduction, while I am with the Alzheimer's Association, and that is my full-time job, part of that role is I sit on a work group supported and ran by the Colorado Department of Public Health and Environment that is working to implement a state plan, so a statewide plan specific to Colorado, to address the increase awareness and prevalence of Alzheimer's disease in our state and the needs of Coloradans. So one of the activities from that state plan that Colorado CDPHE, so the Colorado Department of Public Health and Environment, has decided to prioritize is education around dementia and brain health. And that is not only for those who are currently facing dementia, so possibly someone with symptoms or their care partners and their families, but the general public, people who may have a neighbor or a friend, or who may know more people with dementia in the future. And so I'm going to just plop this plan into the chat here. I think maybe I think I can use the chat. Oh, I see. I can message hosts and panelists. So I'm going to do that. And I'll ask Sue to just include a copy of this in the follow-up communication of this webinar, so you can kind of get a bigger picture if you're interested in public health and what the state is doing around this topic. But really today represents a truly joint venture of not only CSU engagement extension coming together with the Alzheimer's Association and CDPHE, but other organizations working to just expand awareness around this very important topic in Colorado. Like Sue noted, today's webinar is going to cover a lot of information. We have called this kind of everything everyone should know, or what you really should know, kind of the essentials, if you will, on Alzheimer's disease, dementia, and brain health. So certainly we're going to go over a lot of information somewhat on a surface level, but know that there are more educational opportunities available if you want to take a deeper dive into any of the topics discussed today, or possibly you're a care partner and you want to learn some caregiving strategies. This is really just kind of the starting primer. The larger community and Colorado Department of Public Health and Environment and many other organizations like Extension and Engagement are talking more and more about Alzheimer's and dementia because we are facing an increase in the prevalence of this disease. So I have a graph here that shows the projected number of people age 65 and older in the US, and the expected increase in that number from 2020 to 2060. And simply put, the number of Americans living with Alzheimer's disease who are over age 65 is expected to double by 2060. So we are expecting a significant increase in population of people living with Alzheimer's and dementia. And so with that, more and more people are needing information around this topic. Now, I won't go into this graph too much, but you can see here that currently in 2024, we have over 7 million Americans living with Alzheimer's over age 65. And this graph breaks it up by age. So it breaks it up by ages 85, 75 to 84 in the orange, and then the turquoise represents those 65 to 74. But when we look at that expected increase by 2060, which is really only 35 years away, even though it feels much further out, we expect that number to jump up to nearly 14 million people. So the population of people living with dementia is expected to double. Now, many people ask why this is. Not only are we seeing improved diagnostics, so more people are being formally diagnosed with Alzheimer's, whereas in the past it might have been suspected or not documented by medical professionals. Right? We may have known that grandma had dementia, but it was never formally documented. So in addition to improved diagnostics that come along with a general improvement in awareness and kind of an advancing treatment landscape, we're also seeing larger groups of people living longer. So many people talk about our baby boomer generation, our largest group of population over age 65, living longer. It is more common to live into your late 70s and 80s now than it was in the past. So there's kind of a variety of things going on here, but truly a change in population that me as a gerontologist, I'm interested in, because we have, again, a larger group of people living longer, but also more complexity and diversity in that aging population. We have not only those in their 60s, their 70s, their 80s, and now their 90s. Now, when we look at this data and how it impacts Colorado, so let's take, that was national data. Let's take it down just to a statewide level now. We know that as of 2020, so that's kind of the most recent data we have, there are nearly 91,000 Coloradans living with Alzheimer's disease who are over age 65. So that does not include those with younger onset, and I'll get to that population in a minute. We expect that this number will rise significantly as well. So when we look at Colorado's population of 65 and older, not including those with Alzheimer's, we know that Colorado's 65 and older adult population will double by 2025. And because age is the #1 risk factor for Alzheimer's, we know that people living with Alzheimer's will also rise pretty significantly. Now, Alzheimer's and other dementias are what we call a family systems disease. So not only do they impact the person with Alzheimer's, but it impacts, especially as the disease progresses, everyone around that person, their family system, whether that's formal blood-related family or chosen family or informal family. And currently we have 177,000 Coloradans serving as unpaid caregivers, providing about 307 million hours of unpaid care each year. So this condition, this disease, from a statewide public health perspective, certainly impacts nearly every corner of Colorado. And so that's why today's conversation is so important. When these slides are sent out, you can review a little bit more of the data, but those are the essentials that I wanted you to know, from kind of why you're hearing more about this, why CDPHE and other organizations have taken this on and written the state plan. And it is because not only a national increase in prevalence that we expect over the coming decades, but also an increase in prevalence in Colorado. Now, I noted that age is the #1 risk factor for Alzheimer's disease. What we like to say at the Alzheimer's Association is that Alzheimer's is not kind of a normal part of aging. So there's pathological and biological processes that happen as we grow older that are simply due to age. Alzheimer's disease represents an underlying biological change in a disease process, and I'll describe it in a minute. So while it is not a normal part of aging, age is the main risk factor. So when we look at the population of people over age 65, someone's risk for developing Alzheimer's doubles every 5 years. So their risk doubles at 65 to 70. Now, when we look at the kind of incidence numbers, if you will, we estimate that about 1 in 9 over age 65 has Alzheimer's disease. When we look at that number over age 85, it's about 1 in 3, or what this slide here says, 34%. After age, other prominent risk factors include what we call modifiable risk factors and non-modifiable risk factors. I'll get to the modifiable risk factors. So these are things that we can do regardless of our age. So across the lifespan, to take better care of our brain as we grow older. But these non-modifiable risk factors are things we can't change, right? They are innately who we are. So the first one is age. Age is the main risk factor for Alzheimer's, and it is a non-modifiable risk factor. Others include family history and genetics. It's important to note that family history and genetics are two different things. Family history is simply having a close family member, such as a parent, a sibling, or a grandparent who had the disease, whereas genetic risk factors are actually based on genetic statuses. And I won't go into too much around genetics, but it's important, I think, for the general public to know that family history and genetics are two different things and are the second most common or prevalent, rather, risk factors after age. Now, we know that with genes, there's kind of two different types. There's deterministic genes. We have that gene, we will get Alzheimer's. This type of gene, when it comes to Alzheimer's disease, is very, very rare in the population. So I won't spend any time going into the deterministic gene that causes Alzheimer's. Again, it's incredibly rare, and the large majority of people, if not all people with this gene, are enrolled in clinical trials. They know they have it. But for the general public, there's what we call a risk gene. And it is associated with our APOE gene. And based on the mutation of this risk gene, it either increases our risk for Alzheimer's, neutralizes our risk for Alzheimer's, or decreases our risk for Alzheimer's. Now, even though it is possible to find out your genetic status of this risk gene, it's not recommended that people go out and find out their status, because in the plainest of terms, there's not a whole lot we can do with that information. However, this type of genetic testing, so seeing someone's APOE status, is more and more commonly used in the diagnostic process because it can help us or help the medical field at large either kind of rule out or rule in if Alzheimer's disease is the cause of what's going on. Now, many people say, oh, well, I don't have anyone in my family with Alzheimer's, so I'm good. And I always say to them, it's so fortunate that your family hasn't been affected yet. It's a horrible disease, but it's not that simple. So even families or people without any family history at all are still at risk for developing Alzheimer's disease. Age is really the #1 risk factor. Family history and genetics just kind of add a little bit more risk to that. And I'll go into risk factors later on again when we start to talk about modifiable risk factors, things that we can do to lower our risk regardless of our age. Now, we know that there are certain populations of people who are at higher risk. So we see higher prevalence and incidence in certain populations of Alzheimer's disease. We know that the Black and African American community are about twice as likely when compared to the general white population to develop Alzheimer's. So they are at a significantly higher risk. Hispanic and Latino Americans are 1.5 times as likely to develop Alzheimer's disease. Now, almost 2/3 of Americans living with Alzheimer's are women. So women carry a higher risk of living with this disease than men. And that's not controlled for race. So that's across racial and ethnic groups. Now, for years, people have thought, well, women just live longer. But what we're finding in the research is that there are other factors that could be causing this increase in risk in women. Now, it's also important to note that women carry the large majority of the caregiving burden or the caregiving responsibility as well. The vast majority of family and unpaid caregivers are women, often adult daughters even, many of whom still have young kids in the home and comprising this sandwich generation. It's also important to note that not only are these communities of color impacted at higher rates. So we see higher rates of disease within these communities of color. But their journey throughout the disease is further compounded and complicated by challenges in navigating the healthcare system or facing discrimination in healthcare. And so not only does the Alzheimer's Association, but Colorado Department of Public Health and Environment sees these populations as one to pay special focus on to address these health inequities in our state plan. Now, I mentioned that age is the #1 risk factor for Alzheimer's. And when we look at over age 65, about 1 in 9 is expected to have Alzheimer's. I'd be remiss to not mention a little bit about younger onset Alzheimer's. Some people reference this as kind of early onset Alzheimer's, but I think that's confusing because it gets confused with early stage Alzheimer's. So younger onset Alzheimer's implies that someone's symptoms, so their cognitive changes, started to present before age 65. It's much less common. And we expect that among kind of the 6 to 7 million Americans living with Alzheimer's, a very small percentage of them have younger onset. And so people living with younger onset Alzheimer's, however, even though they are a smaller group in population, their journey is even more complicated because of their younger age. They face unique challenges getting a diagnosis. Their symptoms might be brushed off as stress or menopause or depression at midlife. And they experience different difficulties in kind of some of the financial issues and relationship changes related to Alzheimer's. So people with Alzheimer's can be under age 65, just a very small part of the population. I'll punctuate that even with the changes in diagnostics, getting a diagnosis for younger onset Alzheimer's can be really long and frustrating for people. Again, their symptoms may be incorrectly attributed to stress, or they simply might be told, you're too young to have Alzheimer's, it's got to be something else. And so even though age is the #1 risk factor for Alzheimer's, and most people with Alzheimer's are over age 65, across the population, a conversation on brain health and our cognitive health is very important. Now, you've probably noticed that I've been using Alzheimer's and dementia somewhat interchangeably. Now, a lot of the data that I was presenting is specifically and explicitly Alzheimer's disease. And that's because it comes from diagnostic data, whereas the diagnosis was specifically Alzheimer's. But some of our data sets are Alzheimer's and other dementias, and we talk about Alzheimer's and other dementias together. So let's clarify some terminology. Dementia is an umbrella term used to describe a variety of symptoms. Symptoms that are related to our cognitive changes. So our brain is our cognitive organ, and we do a lot of, in very kind of basic terms, cognitive things every day. We remember things, we repeat things, we think, we learn, we manage our mood and our personality, we navigate. Those are all parts of our cognitive organ, which is our brain. So dementia, again, is a term for changes in those cognitive abilities. Changes in not only memory, can be memory, but it also can be changes in reasoning, changes in thinking and learning, changes in behavior and mood. Now, we all have good days and bad days, right? And I'll get to kind of what's normal aging and what's considered dementia. But dementia is when these changes are severe enough that they impact someone's ability to lead their daily life as they always have led their daily life. Now, there are different types or causes to dementia. Alzheimer's disease is the most common type or cause of dementia. Alzheimer's disease is a disease of the brain that causes about 60 to 80% of all dementia. So that's why they get interchanged, just because Alzheimer's is the most common type or cause. So what I like to say, and I think this is kind of an interesting way to think about it, an easy way to think about it, is for a family member, possibly they're noticing changes in memory, behavior changes, issues with thinking and learning, following instructions in a family member. Those are the dementia symptoms. If that person's symptoms are caused by Alzheimer's disease, Alzheimer's would be what's going on in the brain. It's the disease happening in the brain. It's a specific disease process. So again, Alzheimer's disease causes 60 to 80% of all dementia, but there are other causes to dementia listed here, such as vascular dementia, dementia with Lewy bodies, frontotemporal dementia, and other dementias, including Huntington's disease and even mixed dementia, whereas someone can have more than one cause of their dementia. But when we start to talk about the biology, kind of that what's actually happening in the brain when someone has Alzheimer's, Alzheimer's disease is a different disease in many ways than Lewy body, frontotemporal dementia. And so that's why we advocate to determine what is causing the dementia through an accurate and early diagnosis. So like I said, Alzheimer's is a brain disease, so it is a unique biological, pathological disease in the brain that causes problems primarily with memory, thinking, and behavior. Symptoms might be very mild at first, so someone may delay in their word retrieval at first, kind of in those early stages, but eventually as that disease progresses throughout the brain and affects many different parts of the brain, symptoms become more pronounced or more severe, and someone may have no short-term memory at all. So Alzheimer's in particular is progressive, meaning that the disease starts in a particular part of the brain, and that disease spreads throughout the entire part of the brain, making symptoms more pronounced or severe over a series of years. Eventually, because the entire brain is affected and someone's very basic abilities are controlled by their brain, if individuals will need around-the-clock 24/7 care. They'll need help with very basic activities like grooming or dressing or eating, but they'll also need 24/7 supervision for safety. And that's why this disease is so it can be so cumbersome on caregivers because of that eventual 24-hour round-the-clock care necessary. Eventually, someone can die from Alzheimer's when it reaches the part of the brain responsible for our very, very basic functions. And it's hard to estimate the length of time someone will have Alzheimer's. It's hard to kind of create a timeline for this disease. And that's why it's so frustrating for families. Families want to know, how long will this last? And when can I expect other changes? There's truly no good and precise timeline with Alzheimer's. And that's very frustrating to families, right? When we are facing a health condition, we want to know what to expect and when. Someone can progress through Alzheimer's ranging from a few years, a handful of years, up to 20 years. And so it really just depends on the person, their health condition otherwise, and the quality of care that they're getting to maintain their health throughout the disease. So that's a common question people have is, well, how long does it last? And it really depends on the person. And so there's not even a good time frame. So we often say it can be a couple of years, 5 to 8, up to 20 or more. Now, this is a picture actually of what happens to the brain when someone has Alzheimer's. So when we look at a brain, and this brain is cut, if you will, it's not a real brain, it's a graphic, but it's cut as if it went like a slice down this way. So we have the front part of the brain and the back part of the brain, but it's a slice of the brain, if you will. Our normal brain and our neurons, so our brain cells, are responsible, like I said, for very advanced things and very basic things. And on the left, or at least the left on my screen, there's a normal, healthy brain, so no disease. And then on the right is a brain that is shown to have been affected by the progression of Alzheimer's disease. So, Alzheimer's disease, compared to those other causes of dementia that I mentioned under that umbrella, like frontotemporal or Lewy body, Alzheimer's disease has the pathology, a unique pathology that is associated with amyloid plaques and tau tangles. So these are proteins that occur in our body, but when someone has Alzheimer's, they're at an elevated level. Amyloid plaques and tau tangles develop inside the brain neurons and outside the brain neurons. And at first, they delay the brain cells' abilities to do their job. But unfortunately, over time, the brain cells die and we start to see atrophy, actual brain shrinkage due to these plaques and tangles. Now, that is why certain function like short-term memory, reason, are lost because that part of the brain responsible for that task or ability has died. And it's a very medical way of thinking about Alzheimer's disease, but to me, it is a very visual way as well of understanding what's happening when someone has dementia. And certainly, I think it can give family caregivers a little bit more empathy when someone repeats the same story 10 to 12 times. Because, simply put, that part of the brain that was responsible for creating that memory is either not working or it's no longer there. And so it gives us a framework to understand that there's a medical, biological, pathological process happening in the brain. Now, what's interesting is Alzheimer's disease, because it is progressive, happens along a continuum. Research is showing, and this is not impacting the population right now outside of clinical trials, but research is showing that there's this asymptomatic phase, whereas the disease develops in the brain 20 years or more before someone has cognitive changes. So the ability to detect this disease in this asymptomatic phase when someone has no cognitive changes is really changing and improving the landscape of clinical trials. Now, there's also what we have kind of mild dementia, moderate dementia, and severe dementia. And the definitions are described here. So mild dementia includes maybe more mild symptoms that interfere with some daily activities. So someone's word retrieval may be a little bit slow, but they're still able to get by rather independently. Moderate dementia, when the symptoms that are starting to interfere with more or all activities of daily living. And then severe dementia is considered when nearly all activities of daily living plus someone's physical abilities are impacted by the disease. And so it happens along a continuum. And what we are advocating for through the state plan and at the Alzheimer's Association is an earlier and earlier diagnosis. In the past, people were generally diagnosed maybe even in the middle to late stages because their changes were so obvious, right? It was clear what was going on. But through advancements in diagnostic tools and changes in the way that medical care is delivered, more and more people and are hopefully advocating for themselves for cognitive screenings to detect the changes earlier. Now, you may be hearing this MCI, or mild cognitive impairment due to Alzheimer's. This is when subjective changes, so someone may notice changes in themselves, or subtle changes. So there's subtle changes to their cognition, but they're not impacting their daily life yet are occurring. But the symptoms aren't considered pronounced enough to be dementia. So now there's this kind of MCI due to Alzheimer's phase. And frankly, more and more people are being diagnosed in this phase where their symptoms, their cognitive changes are subtle enough. They're noticing it, their family is noticing it. The medical tests that their providers used are able to pick them up, but the changes aren't pronounced enough to be dementia yet. So it's important to think of this kind of along a continuum as a progressive disease. Now on the screen here, we have what we call our 10 early. So these would be kind of changes that happen in that earlier mild stage of Alzheimer's disease dementia. And we like to go over these or provide these to audiences because many people hear Alzheimer's and dementia and they think memory loss. They think, oh, someone's going to be forgetful or repetitive. Short-term memory loss is only one of the early kind of warning signs or the early symptoms, if you will, of Alzheimer's. Now, it also includes challenges in planning or solving problems and difficulty completing familiar tasks, like following a recipe or following instructions to put something together, whereas a few years ago, someone would have been able to do that. Confusion with time or place. So possibly not just kind of forgetting the day of the week, but having such challenges with managing a calendar that their ability to show up to appointments is completely unreliable. Trouble understanding visual images and spatial relationships. A good example of this is starting to struggle with drawing a clock at a certain time or interpreting a clock at a certain time. New problems with words and speaking or writing. Now, we all forget what something is called every now and again, but this is when someone truly loses the ability to retrieve that word. Misplacing things and losing the ability to retrace steps. So we've all lost our keys, but if we're able to remember what we were doing last time we had our keys, to retrace our steps to find them, that's a normal recovery from a memory lapse. But if someone is misplacing things so much where they're unable to keep track of things, that would be an example of what number 7 is talking about. Decreased or poor judgment, withdrawal from work or social activities, and changes in mood and personality. Now, it's important to note that people are unique, and individuals may experience one of these, some of these, all of these, to varying degrees. Additionally, we all have different abilities throughout our lifespan. Someone may always have been really good with names. Someone else may never have been good with names. But when we notice the changes in an individual's kind of baseline abilities, that's what we're talking about here. Now, a good example of kind of when it's considered normal age-related changes or kind of normal cognitive lapses versus symptoms of dementia is what I say the ability to recover. Again, we all forget what something is called, but if I'm able to recover or retrieve that word, I was able to kind of overcome that memory lapse. So here we're talking about one or some of these signs happening so much where someone's unable to recover and it's starting to impact their daily activities. If you notice these changes in yourself or someone else, please don't brush them off as normal aging. That's what's happened in the past. Oh, of course they're repetitive. They're older. But again, dementia and dementia due to Alzheimer's is not a normal part of aging. It's a disease happening in the brain causing those changes. So it's always important to talk to a medical professional to determine what's going on. Often people will ask, well, what's the point? What's the point in addressing these cognitive changes with my medical professional? There are so many arguments around the importance for early detection and so much data that's been populated around why early detection matters. But it's important to just pay attention and any changes in your memory, thinking, or behavior that you notice in yourself or someone else. There are so many tools out there to kind of track and document these changes, to put them in a language that you can take to your medical professional to address the concerns that you have. And you can take action by talking to your doctor or disclosing your concerns with a family member or friend. A doctor can and should, due to the annual wellness visit and what's covered at the annual wellness visit, be doing basic cognitive screening at the annual wellness visit for people insured by Medicare. But often what we see happen is that's not happening at all. Cognitive health is only addressed when the symptoms are so pronounced that it's more clear what's going on. And so sometimes a patient may have to advocate for themselves or take action and actually request a cognitive assessment from their provider. There's a lot of benefits to detecting these changes early and not waiting until they become worse. Someone is able to plan for the future. Even though they might have very subtle changes, they hopefully still have the capacity to participate in this planning. They can explore treatment options that are ever changing. The Alzheimer's treatment space is changing almost weekly in terms of what's available to patients. They can participate in clinical trials and make important decisions about their future care, including putting together maybe a bucket list or kind of their wishes for their last phase of life. There's a misnomer and a misunderstanding out there that Alzheimer's cannot be diagnosed when someone is living, and that is false. Due to advancements in our understanding of the disease and advancements in some of the assessments used, evaluating memory and thinking problems can happen at the primary care level. And what's causing those changes, Alzheimer's disease or something else, can be determined when a person is living. So what might happen is there might be a short cognitive assessment where someone is given very basic questions to kind of create a rating for their cognitive ability. Now, if that presents that someone is having cognitive impairment that is representative of mild cognitive impairment or dementia, there are further steps that should be had to rule out things that could be causing those changes that are reversible, or determine if it is Alzheimer's disease or another cause of dementia. So these assessments to rule out other things or rule in Alzheimer's disease or the other dementias may include a medical history, a physical exam, screening for depression, and an interview with a trusted family member or friend to get more information on what changes are happening. From there, they might run laboratory tests like a urinary analysis or blood work. Hopefully they'll do a medication review. They'll possibly do brain imaging like an MRI or a CAT scan. Certainly there are advancements in PET scan technology, and I won't go into all of that in too much detail, or a cerebral spinal fluid analysis. Again, what these tests are looking at is after the impairment shown on one of these cognitive assessments that a doctor does, they're going to want to rule out possibly depression, medication interactions, urinary infections that could be causing that impairment before they rule in something like Alzheimer's disease that could be causing that impairment. It's important to note that current medications cannot cure Alzheimer's. So there is no cure to Alzheimer's, but there are treatments, and this is an ever-changing space over the last 2 to 3 years, that can actually change the progression of the disease. So you may know of Leqembi or donanemab, which received FDA approval just a few weeks ago. Those are the first treatments that actually reduce that amyloid plaque in the brain. There are other drug and non-drug options that can help manage some of the symptoms, like confusion or agitation. But it's important to note that because everyone experiences Alzheimer's differently, some of these treatments are appropriate for some and may not be appropriate for others. So work with your doctor to determine kind of what is best for that patient. Now, it is important to note that particularly with these new amyloid reducing therapies like lecanemab and donanemab, they are contingent upon Alzheimer's disease being in the brain seen through a PET scan. So that's why seeking that early detection, but also that thorough diagnostic process is important, is because as the treatment landscape changes, the diagnosis of what's causing the cognition and the dementia is important. Now, I want to talk a little bit before I start to wrap up about the impact on families. We know that caring for someone can take a physical, emotional, social, and financial toll. I noted that a large majority of dementia caregivers are daughters and even sandwich generation caregivers. And when we look at dementia caregivers compared to other caregivers, to those without dementia, caregivers to those with dementia experienced much higher levels of emotional, financial, and physical difficulties. That's because they have higher levels of depression, anxiety, and also higher levels of out-of-pocket care related expenses. So again, I'll share these slides so you have this data, but I want to paint a picture of the reality that caregiver stress as it relates to dementia caregivers is real. Some of the signs of caregiver stress may be denial about the disease, anger or irritability, withdrawal from friends and activities, often because of the 24/7 care, new levels of anxiety and depression, sleeplessness or exhaustion, lack of concentration, or their own health problems. Data shows that the health of caregivers is often worsening or declining at a higher rate than the person with Alzheimer's. So caregiver support, caregiver education is a very important conversation to be had, because not only does the disease affect the person with Alzheimer's, but it affects the caregiver. The Alzheimer's Association has a fabulous 24/7 helpline where people can call this number day or night at 2 o'clock in the afternoon, 2 o'clock in the morning, on Thanksgiving, on 4th of July, what have you, and speak to a master's level dementia expert to receive emotional support or just tips to maybe manage a difficult situation. That resource is available in English and Spanish. We also recommend that caregivers take care of themselves, take care of and prioritize their physical health, and to take a break. Now, I'm going to end with a little bit of information on brain health. So I talked a lot about how dementia is becoming more prevalent in older populations. Advancements in diagnostics are hopefully allowing people to receive better and more accurate information in the earlier part of the disease. But we all have brains and we all are aging. Each and every minute, I hope to have the gift of growing older. And research is showing that how we will cognitively age, so how we will experience cognition in later life, is impacted by things that happen throughout our lifespan. So there are several risk factors for cognitive decline and dementia that are non-modifiable, right? I mentioned age, genetics, family history. But there are things that we can start doing, whether we are 20, 40, 60, whether we have no cognitive impairment, and even if we have dementia, there are things that we can do to better take care of our brain to improve our brain health. Now, we know that increasing kind of key health habits will lower our risk of cognitive decline. We're not in the time yet where we have enough evidence to say prevent cognitive decline. But it's important to know that it's never too late or too early to start taking care of our brain. So you may ask, what is it that we actually have to do? First and foremost, I want to highlight what's listed on the right side of at least my screen. There is a significant connection between our heart and our brain. So the basic foundation of brain health and lowering our risk of developing dementia starts with our heart, managing our blood pressure and managing diabetes. So those two health behaviors and paying attention to those numbers, if you will, also benefits our brain and our cognition. And that is because our brain does a better job of pumping oxygen, blood, whatnot, to support our neurons in our brain doing their job. We want to get enough sleep. Quality sleep has been shown as a significant risk reducer for dementia. Protecting our head, particularly avoiding traumatic brain injuries. So wearing a helmet across the lifespan, whether it's while skiing or while rodeoing, riding a bull, for example, wearing a helmet in any of those activities and just protecting our head in general is a significant risk reducer. Avoiding TBIs in particular, quitting smoking. But what also matters is getting enough physical exercise, maintaining a healthy weight, avoiding obesity in particular, and eating right. The diets that have been best studied, and I mean ways of eating, not crash diets where you go on it and you go off of it, are the MIND diet, the DASH diet, and the Mediterranean diets. Now, without physical exercise and a proper diet, what I've been told is none of the other health behaviors will do much good. So really, physical exercise and diet are the foundation of brain health. Things that also help are staying in school and continuing to challenge your mind through social and cognitive engagement. But again, without some of those heart healthy behaviors, those won't have much as impact. They won't hurt certainly, but they won't have as much impact. Here I have listed just how we can help and how you can get connected for additional services. But as I wrap up and pass the mic to Joy, is that we are looking for partner organizations, groups, people to help spread this education. So I've listed kind of some of the opportunities to either host an online or in-person education like this one, where we'll supply a speaker. If you want to get plugged in as an educator, or if you just want to help spread the word and share resource materials. Those are kind of three opportunities to take this to advance in your community. And I think Joy is going to provide a really brilliant framework for how CSU engagement has made that connection between community engagement and dementia. And then I also included some of the deeper dive topics that we can go into. All right, I think I am on my side, okay, 2 minutes over, but thank you so much for listening. And I pass the mic and screen to Joy to continue the conversation.
So I'm going to jump in and just say thank you so much, Kelly. So much valuable information. We do have a question about resources for family caregivers, and we'll make sure to address that after Joy has a chance to speak. But I do want to introduce Joy to you all. And so she's going to be talking about applying dementia education in communities through extension. And so for those of you who do not know Joy Akey, she is a family and consumer science specialist for Colorado State University located in Yuma County on the Eastern Plains. Joy has served in this capacity for over 30 years, providing community education for all ages in a variety of topics such as nutrition and health, food safety, financial well-being, and family and youth development. There are numerous things that have led Joy to a long career in extension, including the variety each day brings and the amazing people she is privileged to work with. And in her spare time, among some of the things Joy enjoys are spending time with family, outdoor activities, and traveling, probably the very things that do prevent Alzheimer's. So I'm thrilled to pass it off to you, Joy.
Thank you, Sue, and thanks again to everyone for joining us today. I am here representing a team of family and consumer science extension specialists here in Northeast Colorado that have worked at trying to provide some additional dementia education in our rural communities. And a lot of what Kelly shared today really resonates and connects with our work here in Northeast Colorado. So as you know, and we've heard already, dementia touches many people, and oftentimes those living in rural communities have very limited resources to support those with dementia and their families and their caregivers. We typically have limited to no dementia care specialists, and caregivers are frequently worn down from stress and the challenges of trying to give adequate care. Oh, sorry, I meant to advance my slide here. Along with that, we know that there's a lack of choice. So there's typically not a lot of additional care support available in rural areas, and this often leads to the only choice being a long-term care facility, which in turn for some can lead to feelings of guilt and additional stress for the caregivers and the families. On top of that, we know that statistics show in the last 5 years of life, and again, Kelly touched on the expense, but a lot of average out-of-pocket costs for older people with dementia are significantly higher than for older people without dementia. And a lot of that cost is related to just that additional support care for the daily tasks that they need help with, and meals, dressing, just other daily activities, which are a very large part of their needs. And those sorts of costs are not generally covered by any kind of insurances. So it's a lot of out-of-pocket expense. We also know that families spend a larger share of their assets on dementia care than on care for other conditions. And most of that spending, again, is on long-term care, whether that's in facilities or in-home care. And we've seen in some of our rural areas that can even come to the expense of losing the family farm or ranch just in order to cover those costs. So it's very significant. All of the family consumer science extension specialists in Northeast Colorado on our team have been personally touched by one or more of these factors. And we knew of many others in our communities who were struggling with these issues as well. So kind of as the true extension way, we recognized a local need and sought out ways to make a difference. And this led us to partnering with Jill Couch, who is a licensed occupational therapist and a certified Dawn dementia specialist, to increase the caregiver awareness and knowledge and provide additional resources and supports for the families in our communities. And Jill not only does this professionally, but she was actually inspired to do this to become a dementia care specialist after watching her grandmother go through Alzheimer's disease without dementia care specialists. So that was kind of her trigger to come into this profession and help our team with dementia care and education. So what she did is she started out with Gifts of Dementia program, and she did that in 6 different sites here in Northeast Colorado. And Gifts of Dementia is an introductory presentation that basically where she shares hope in dementia and how we provide care. And she focuses on strength-based, person-centered care so that when we are looking at a person with dementia, we look at the whole person and work on focusing on what they can do versus what dementia takes away. And she shared with us that people with dementia are losing their rational thought, but they never lose their intuitive view. So they're always living in the moment. They can still appreciate beauty and music and nature and the things that they enjoy. And if companions and caregivers are taught to support those strengths, there is less stress for the person with dementia as well as the people who are caring for them. So Gifts of Dementia created a better understanding of dementia in general, along with increased awareness of how to better care for people living with dementia. And it also provided kind of an inside glimpse of the Dawn training series, which I'll provide a little more information on too. Our post-survey feedback and conversations with attendees confirmed that there really was a need and a high interest to move forward with offering more in-depth programming. So that led us to partnering with Jill to provide the Dawn method training. And Dawn stands for Dementia and Alzheimer's Wellbeing Network. It's an evidence-based dementia care method that was created by Judy Cornish. And again, it focuses on that strength-based, person-centered care for dementia. It's an 8-week training, and it provides education and knowledge and awareness about dementia, but it also provides specific tools that meet the emotional needs of people with dementia related to mood management, security and confusion in care, social success, a sense of control, value, and a secure future. Dawn empowers families and caregivers to help extend a more comfortable environment by reducing stress and just creating more happiness revolved around those components. Dawn was developed specifically to help families care for loved ones at home and to help keep folks at home longer. And that it also extends to lower societal costs and just better family and social well-being, and to help the process be more comfortable for everyone. However, Dawn also is very valuable for people who do provide caregiving on a professional basis, or anyone who is interested in dementia care or our healthcare providers. So it can be applied in a variety of realms. So what we did is we started out with a hybrid class the spring of 2023. Jill was in person at our site located in Sterling, and then people joined us virtually around the region. And we had a lot of really great input, that there was a high interest in, again, trying to do another Dawn class and to provide it in the southern region of our area. So that led us to partnering in kind of a very unique way with a high school student who was an FCCLA member at the Holyoke High School. So we partnered with Ellie Brown, and this was our agent in Phillips County, was more instrumental in this. She was very involved in this trick or trot, but Ellie and Extension organized a trick or trot for dementia event. And this collaboration was aimed to raise awareness about dementia and then also to help us secure some additional funding to provide our second Dawn method training. So Ellie's FCCLA project was a student-led initiative that addressed a community need or issue. There were 74 participants who ran or walked the route that passed along the local assisted living and nursing home along the way. Participants were encouraged to wear costumes or dress in purple to raise awareness about dementia. Their local volunteer fire department provided a free will donation meal, and then Jill presented on dementia in general and gave some information about Dawn and had a Q&A session, so it was very informative. The Trick or Trot raised over $1,361 with 15 businesses who sponsored the event and or contributed to the Dawn method training specifically, for a total amount of funds raised of over $3,200. So it was a really successful event. And LA, just as a side note, she received a first place on her FCCLA state conference at that conference for her project, and is going on to nationals because of that too. So she really was a unique contributor in helping us raise awareness about dementia and support our education in our communities. So that helped us extend the training for Dawn onto our Ray site. And I wanted to touch base a little bit about the funding for our Gifts of Dementia and Dawn method training. Just due to program licensing and regulations, the required fee for these programs are pretty much set. And our team we were super excited to have Jill be a partner with us and provide extremely valuable resources to our communities. So we did not want a financial burden to be a barrier for people to attend these. So we expanded our reach, our partnership network for dementia education, to include schools, local hospitals, banks, and other businesses and organizations. We had a Ray community member who serves on our El Pomar Regional Council. She partnered with us and provided an additional grant to focus on dementia education here in our rural areas. And along with the Trick or Trot event, we had other community businesses and partners support our efforts. So, and in addition to that, we received rural initiative funds through Extension. So all of these components help provide scholarships for the people who may not have otherwise been able to afford the cost. And they also helped us cover a resource book for everyone and provide some additional funds to support the mileage and fees for Jill to come present. We wanted to share, I know this is a really busy slide, but we just wanted to kind of give you a glimpse of the impact, excuse me, that the Dawn training provided for people. These are kind of snippets of some of the thank yous that people provided to our sponsors. And I think you can see just in that 8-week time frame, it really had a powerful impact. And we did a pre and post survey, and just one of the things I wanted to point out was that we had almost a 30% reduction in perceived caregiver stress from the first week to the final week of our program. And as Kelly noted, stress is a huge factor for caregivers. And so that was pretty inspiring to see that they really felt the training had made a difference, and it helped them significantly to help care for their loved one with dementia. So what's next for our team? We would sure like to continue on with dementia education in our communities, because we know it's truly a need and an interest. We were able to serve a variety of people with Gifts of Dementia and the Dawn programs, and that included both caregivers in the home, as well as family members and professional healthcare providers and caregivers. So we felt like we reached a broad audience, which was exciting. And we had several people ask, so what about a Dawn 2.0, or what's next? And can you continue to provide support and tools to help us care for those that have dementia? And so we are hoping to pursue that opportunity with Jill and extend that kind of Dawn 2.0 training on to our communities. We also have a potential for a Dawn training that's targeted specifically for professional caregivers. And one of the local hospitals in our area is interested in piloting that program. So that may be an opportunity here in the future. And then our extension team is, again, very interested in helping to promote and provide access for additional educational resources to support and benefit those members in our community. So we're anxious to see what other opportunities and avenues there are to help our communities. So that that's kind of our plan for next steps. So thank you.
Fantastic, Joy. Thank you so much for sharing that local case study. And I think it's just super helpful to know about different kinds of resources and approaches. I think I'll jump into a relevant question at the bottom of the chat here, just to find out from you, Dawn, as a follow-up. Is the Dawn training available in Spanish? Lisa's asking.
That is a good question, and I am not certain about that, but I can look into that and get an answer for you.
And maybe we can ask Kelly as well, because I know you have a lot of resources for Spanish speakers. Kelly, do you want to talk about Alzheimer's training and resources available for Spanish speakers?
Yeah, so the Dawn training sounds excellent, and I think just kind of represents one educational way to learn about dementia and Alzheimer's. But I'll speak to kind of what's available through the Alzheimer's Association, which is what the Department of Public Health and Environment is using, and they're using it because of its availability in Spanish. So the last slide I showed that will be shared has kind of two buckets of topics. So general education and caregiver information. So with that, what falls in the general education is like understanding Alzheimer's and dementia, 10 signs and how to get a diagnosis, and then healthy brain. And then what falls under caregivers, and what we call our Empowered Caregiver series is communications, understanding behaviors, care strategies, caregiver stress, care options. Those courses through our on-demand online learning platform are available right now in English and in Spanish. Additionally, the curriculum is available in Spanish. So based on where you're joining from, it may not be available yet in person because we need a Spanish speaker to deliver the curriculum, but the curriculum is ready to go. The presentation materials are ready to go. Additionally, we have right now just in Colorado virtual support groups in Spanish, and then our 24/7 helpline that offers individualized assessment, emotional support, care planning, disease education is also always available in Spanish. And then on top of that, the Alzheimer's Association's website, there's tons of information on there. I mean, you can drill down to such a specific topic like dental care and dementia, and that all is available in Spanish as well. And then last but not least, the state is building out resources in Spanish as well.
Fantastic. That is so helpful. Maybe along those lines, so Lisa's also asking what the correlation is between the BIPOC community living within the US and elsewhere and dementia. So the Black, Indigenous, and people of color community, maybe, do you have statistics or information?
Yeah, so again, the Black and African American community is twice as likely. So they carry a double kind of impact, and then the Hispanic Latino community are 1.5 times as likely. So that's just when looking at measures of racial demographics. So the research around why BIPOC communities are impacted at higher rates is quickly developing, and it's being prioritized, particularly by the Alzheimer's Association, to understand why these things occur so that the healthcare community can work to mitigate future health inequities. So there are many things that go into these higher levels of prevalence, and I'll talk about it because the question implies globally as well. But on the national level in the United States, there's research that is exploring what genetic differences there could be, how different communities approach health and lifestyle choices. Of course, we know communities of color also have higher rates of blood pressure and diabetes, which are significant risk factors for Alzheimer's disease and dementia. But what the research is also looking at is the lifelong, so from birth to death, accumulation of health disparities. So how differing access to healthcare or lack of access to healthcare earlier in life affects certain communities in later life. There's been research noted around the impact of racism and how racism has created these higher levels of prevalence. And so it's really kind of a complex answer that we don't have all the information on, but certainly that's kind of where our understanding has been, but also where it's going and what the research community is looking at. On a global scale, the conversation changes because life and access to basic needs and healthcare looks different in each country. And so certainly there are certain communities globally that have higher rates and lower rates. But an interesting study actually came out through the Alzheimer's Association a few years ago that looked at the impact of pollution, for example, on populations of people carrying higher rates of dementia. So needless to say, while we know there are these higher rates, the research is starting to explore kind of the whys so that the systems can change to help prevent some of those higher prevalence rates.
Great, thank you, Kelly. And hopefully, Christian, this answers your question about having info on Alzheimer's disease in the African American community in Colorado. And if you have further follow-up question on that, please feel free to put that in the Q&A box as well. We've got some other questions here. Judy's asking, what is vascular dementia? Can you define that for us?
So vascular dementia is dementia that occurs due to a vascular condition. So a condition of the cardiovascular system that therefore impacts the brain. So this is often kind of how the general public may refer to as dementia that occurs after someone has had a stroke. So sometimes there's an acute medical incident, like a stroke, that has caused damage to the brain because during the stroke, that blood flow was impacted that was going to the brain, and that part of the brain was impacted. So there can be an acute incident that causes vascular dementia, but there also can be just kind of ongoing vascular health issues that there isn't an obvious incident like a stroke that causes vascular dementia, like unmanaged high cholesterol and clogging of the arteries over a period of time, or unmanaged high blood pressure over a period of time. Those things cause damage to the blood vessels and our arteries, and therefore prevent them from doing their job to support the brain, and therefore parts of the brain are impacted. Vascular dementia can look a little bit different in symptoms than Alzheimer's based on what part of the brain was impacted. So we know with Alzheimer's, it starts in a part of the brain that's primarily responsible for reasoning and short-term memory. But someone who has had a stroke and therefore has vascular dementia, a different part of their brain may be impacted. And some vascular dementia isn't as progressive. And through rehabilitation, someone can actually, rehab after a stroke. So that's kind of a broad answer, but there's kind of all these different subsets of vascular dementia, depending on kind of what's caused it.
Great, thank you. We have a question from Trent about if anyone has heard about Dr. Goodenow, I probably said that wrong, prodrome treatment. Sounds like it's been super helpful for his grandmother. Have either of you heard of that?
Yeah, so I believe that this is it stems from a book, Breaking Alzheimer's is his. There's a number of other similar books out there like it. So what I always like to do is answer questions like these very generally. So there are books, products, protocols out there online, in TV commercials that market themselves as a cure or a reversal of Alzheimer's disease. Generally speaking, they do not have the rigorous scientific evidence that the Alzheimer's Association likes to look at to make scientific claims. So a good example of that is Prevagen. Prevagen is an over-the-counter product that you can buy at Walgreens, and it claims to reverse memory loss. Breaking Alzheimer's and other books often are certain type of health assessments and then health interventions that claim to prevent Alzheimer's. If they cite an evidence base, their evidence base often isn't as widely or as rigorously studied as a true clinical study. So they're citing maybe a small pool of data if they are citing data, but it's not as rigorous of data that the scientific and medical community likes to turn to. That's all to say, often their ideas are not bad. So the ideas of many of these protocols are not bad. They are right in line with many of our health behavior for brain health. They recommend exercise, eating right, good sleep, looking at your numbers, managing your numbers. So the ideas behind them are good. They just often oversight data and often are selling a product or a protocol to make money off of it. The best study to turn to because of its scale, so because of how large it is and the scientific rigor going into it, is what was done in Finland as the finger study and is now being done as the US pointer study. Those are the largest studies looking at health behavior, so changes in diet, changes in exercise, changes in sleep, used as an intervention in someone's 60s or 70s to study the impact on cognition. We have data from the finger study, but that's Finland, and the Finnish population is very different and very homogeneous compared to the United States. They have much better access to healthcare for all people, their diet's different, etc. The US pointer study is being done, the Alzheimer's Association is actually running it. More than half of participants come from communities of color, which is critical to understand kind of back to that other question. But it will be the first study of its size with a rigorous evidence base to say doing X, Y, and Z has A, B, and C outcomes. So in summary, often these books, protocols, products, the ideas aren't bad. There just isn't the evidence base to justify the claims they make. And often, you know, they're entering this space to profit off of it. But often the health intervention techniques aren't that much different than you know, what we share in brain health. So that's kind of a general answer to that one. But I mean, it can apply to other books out there. That's just one of them.
Yeah, so you're suggesting a healthy dose of skepticism and rely on the research, and that is fair.
I always say be a savvy consumer.
Be a savvy consumer.
Because there's a lot of good free information out there, and there are a lot of people with good intentions, but they want to make money off of it. And a lot of the information is free. And investing in a gym membership or a little bit, maybe more vegetables might get you a little bit more health outcomes.
Great. So we are at 1 minute here. I am maybe with this 1 minute because this is a question that might be more applicable to everybody, just to reiterate your response to the question about looking for resources for family caregivers to find support. I just have to reiterate that statistic you shared, that a higher level of caregivers have anxiety, that was at 44%, than do Alzheimer's patients have depression. And I know you weren't trying to compare those stats, but it struck me as pretty amazing how high the level of anxiety is for caregivers. So this is really, really important. Just resources, both Kelly and Joy, anything you want to share to close this out?
I'll just share that all of the Alzheimer's Association resources are free, and our helpline, someone can call day or night in English and in Spanish and explore those resources, or just get personalized emotional support in a moment of crisis. But they also can find support groups and education classes. So a great place to start. And that number is 800-272-3900.
Fantastic. And we will send that information out when we do our follow-up. And Joy, any last thoughts for folks, you know, looking for resources in rural communities? You guys have been super creative and how to bring some new resources in. Is there anything you want to say about that?
Well, I think the Dawn Method, of course, has a website too with some free resources, and I think just again partnering, you know, anytime we can make connections with any organization, right, that can provide dementia care education, I think we all benefit from that. So
absolutely. Well, our time is up. I'm super grateful that everyone joined. I'm so grateful for Kelly and Joy bringing their expertise and experience, answering all those great questions. You may have more, but you hopefully will know how to find both of them. We'll again send you that follow-up information with the slides and with the resources. And you know, you can always look at the Extension website as well to be able to find folks in your community that can connect you with resources like the Alzheimer's Association. So again, thanks for joining us, and we hope you can apply this knowledge, and taking good care of yourself, it sounds like, is message number one. That's the most important thing. So take good care, everybody.